So welcome. In today's session, we'll be discussing heart failure, and we'll start off by defining what heart failure is, then look at systolic and diastolic dysfunctions as some from which heart failure results from, and then look at forward and backward failure, and then finish by discussing some of the compensatory mechanisms employed during heart failure. Welcome all, my name is Boris Munir, and I'll be a doctor. Now, heart failure, um, heart failure, which is often referred to as congestive heart failure, is the common endpoint for many forms of cardiac disease, and typically is a progressive condition with a poor prognosis. Give me a minute, I hide this, just a minute, yeah. So it occurs when the heart cannot generate sufficient output to meet the metabolic demands of the tissue. Okay, so congestive heart failure or heart failure refers to when the heart cannot generate sufficient output to meet the metabolic demands of the tissue. Or if it can do so, it can only do so at a higher than normal feeding pressures. Okay. Also, in a minority of cases, heart failure may be defined as a consequence of greatly increased tissue demands, as in hyperthyroidism, or when there is decreased oxygen carrying capacity, as seen in anemia. In anemia, the heart is normal, so there is a high, the cardiac output is normal, but the metabolic demands of the tissue aren't being met. So there is a failure. So this is known as a high output failure. Now, the onset of heart failure is sometimes abrupt, as in the case, as in the setting of a large myocardial infarct. This large myocardial infarct might be caused by like a rupture of an atherosclerotic plaque in the coronary artery, leading to formation of a thrombus, which might occlude the coronary arteries, leading to an abrupt onset of the congestive heart failure. Also, in cases of acute valve dysfunction, that will also lead to an abrupt onset of congestive heart failure. Now, in these cases, however, the congestive heart failure develops gradually and insidiously owing to the cumulative effects of chronic work overload. Okay, chronic work overload or progressive loss of the myocardium. Okay, so that was the definition of congestive heart failure. Next, let's look at what is diastolic and systolic dysfunction. Now, systolic is contraction. Diastole is relaxation. So, systolic dysfunction may result from inadequate myocardial contractile function. And what might lead to inadequate myocardial contractile function? It might be a consequence of ischemic heart disease or hypertension. Okay, so in systole is contraction. So systolic dysfunction is a pumping failure. So the ventricular pump isn't functioning. So that leads to a systolic dysfunction. Now, diastolic dysfunction refers to an inability of the heart to adequately relax and feed. So diastole is relaxation. So diastolic dysfunction is a feeding problem. So the heart cannot adequately relax and feed. So, and this might be a consequence of massive left ventricular hypertrophy, myocardial fibrosis, amyloid deposition, or constrictive pericarditis. Now, approximately a half of the congestive heart failure cases are attributable to diastolic dysfunction. with a greater frequency seen in older adults. So these are the risk groups: older adults, diabetic patients, and women. Now, heart failure may also be caused by a valvular dysfunction, e.g. due to endocarditis, or may occur following rapid increases in blood volume and pressure, even if the heart is normal. So hemodynamic disturbances, even if the myocardial structure is okay, might lead to heart failure. So let's look at the next objective, which was forward versus backward failure. Now, when the failing heart can no longer efficiently pump blood, there is an increase in the end diastolic ventricular volume. And remember, the end diastolic volume was about 100 ml. So if the heart cannot, say, contract properly and eject the normal stroke volume of 70 ml, blood will start to pool in those ventricles. So the end diastolic volumes will be increased, and also the end diastolic pressures will be increased. And also this will lead to elevated venous pressure. So there will be venous congestion. Okay. Thus, inadequate cardiac output, which is referred to as forward failure, is almost always accompanied by increased congestion of venous circulation. Please note that. And this increased congestion of the venous circulation, or the venous congestion, is now the backward failure. Okay. So if you cannot pump out, you accumulate. And if you accumulate, blood will accumulate in the veins, and this will lead to a venous congestion, and that is a backward failure. Now, although the root problem of congestive heart failure typically is deficient cardiac function, virtually every other organ is eventually affected by some combination of forward and backward failure. Okay, so if there is forward failure, you expect hypoxia and ischemic damage to the end organs. If there is a backward failure, you expect congestion. So one way or another, every organ will be affected. So, okay, let's look now at some of the compensatory mechanisms which the cardiovascular system employs. Now, the cardiovascular system attempts to compensate for the reduced myocardial contractility or increased hemodynamic burden through several hemostatic mechanisms. One, the Frank-Starling mechanism. Two, activation of the neurohumoral systems. Three, myocardial structural changes, including augmented muscle mass. Let's look at the Frank-Starling mechanism. Now, the Frank-Starling mechanism, when there is an increased end diastolic filling volume, they will dilate the heart and cause increased cardiac myofiber stretching. Now, these rendered fibers contract more forcibly, with more force, that is, thereby they increase the cardiac output. Okay, so if the dilated ventricle is able to maintain cardiac output by this means, the patient is usually said to have a compensated heart failure. Okay, and you understand why we have compensated it. You dilate, the more you stretch the myocardial, the myofibers, the more they contract with more force, so they increase the cardiac output. So the cardiac output will go back to normal, so the heart failure will be compensated. Now, however, ventricular dilation comes at an expense of increased wall tension, and this will magnify the oxygen demands or the requirements of an already compromised myocardium. Now, with time, the failing muscle is no longer able to propel sufficient blood to meet the needs of the body, and now the patient develops decompensated heart failure. So at first, the Frank-Starling mechanism will help you, but with time, it fails and you develop compensated heart failure. Now, let's look at the second mechanism, which was activation of the neurohumoral systems. Now, one way is release of neurotransmitter norepinephrine by the autonomic nervous system, the sympathetic division. And this will increase the heart rate and We also augment the myocardial contractility and also will increase the peripheral vascular resistance. This will enable the delivery of blood to tissues. Also, because of the heart failure, there will be low perfusion of the kidneys, renin will be released, and there will be activation of the renin-angiotensin-aldosterone system. And we know aldosterone will help in the sodium and water retention, and this will augment the circulatory volume, will increase the circulatory volume, and also, you know, angiotensin will increase the vascular tone, increasing the peripheral vascular resistance. Now, since there is pooling of blood, especially in the right atrium, when we have a right-sided heart failure, there will be release of natriuretic peptide, which will balance the renin-angiotensin-aldosterone system. And you know, A and B usually induce diuresis and also causes vascular smooth muscle relaxation. Now, the third mechanism was myocardial structural changes. Now, the cardiac myocytes adapt to increased workload by assembling new sarcomeres, a change that is accompanied by myocyte enlargement. They hypertrophy. They undergo hypertrophy. So remember, cardiac muscle is a permanent tissue. It can only undergo hypertrophy with no hyperplasia. So this is at the same magnification. You can see these are cardiac myocytes, and you can see the branching, okay? But here you can see that this cardiac myocyte here, it has undergone hypertrophy. You can see increased cytoplasm and increased nuclear size, okay? This and this is before hypertrophy. This is normal. This is hypertrophic under the microscope. Now, pressure overload states. Now, the cardiac muscle might undergo hypertrophy in two states, a pressure overload or a volume overload. Now, let's start with the pressure overload states. Now, in hypertension, pressure overload states occurs in these two conditions, hypertension or valvular stenosis. New sarcomeres tend to be added parallel to the long axis of the myocyte, adjacent to the existing sarcomeres. Now, the growing muscle fiber diameter thus results in concentric hypertrophy. So in pressure overload states, there is a concentric hypertrophy. Now, the ventricular wall thickness increases without an increase in the size of the chamber. Can you look at this left ventricle here? You can see it has undergone hypertrophy. You can see how hypertrophy this muscle mass is. This is a concentric hypertrophy, okay, and due to pressure overload. So what about in volume overload states? Now, volume overload might be caused by valvular regurgitation or shunts. New sarcomeres tend to be added in series, not rather. Remember, in pressure overload, they are being added parallel. This is in series with the existing sarcomeres, so that the muscle fiber length will increase. Consequently, the ventricles tend to dilate, unlike the other one where the ventricle remains the same, and the resulting wall thickness can be increased, can remain normal, or can be decreased. Thus, heart weight, rather than the wall thickness, is the best measure of hypertrophy in volume overload states, okay? So, you can see in this diagram, this is the normal heart. You can see this is the normal myocardium. This is in pressure overload states. See how the concentric hypertrophy, okay? But here you can see the ventricle is dilated, but you can see, in fact, the wall thickness here is decreased, okay? This is in volume overload states. Now, yes, we have compensated, but this comes at a cost. Now, compensatory hypertrophy comes at a cost. The oxygen requirements of hypertrophied myocardium are amplified owing to the increased myocardial cell mass because the myocardial capillary bed does not expand in step with the increased myocardial oxygen demand. the myocardium becomes vulnerable to ischemic injury. Yes, the myocardium is increasing in size, but is the capillary bed increasing? No, it is not increasing at the same rate. So that myocardium becomes vulnerable to ischemic injury. Now, hypertrophy also typically is associated with altered patterns of gene expression reminiscent of fetal myocytes, such as we have changes in the dominant form of the myosin heavy chain produced, and altered gene expression usually contribute to changes in the myocyte function, which lead to increase in heart rate, okay, and force of contraction, both of which will improve the cardiac output, but will lead to a higher cardiac oxygen consumption. Now, in the face of ischemia and chronic increases in workload, other pathologic changes eventually supervene, such as myocyte undergo apoptosis, there will be cytoskeletal alterations, and also there will be increased extracellular matrix deposition. Now, this pathologic compensatory cardiac hypertrophy is correlated with increased mortality, and indeed, cardiac hypertrophy is an independent risk factor for sudden cardiac death. Okay, so that is the cost of compensation. Now, to finish off, did you know this? Volume-loaded hypertrophy, which is usually induced by regular aerobic exercise such as running, also marathoners, Kipyegon, that the heart would be hypertrophied, but that is physiologic hypertrophy. It is typically accompanied by an increase in the capillary density, the heart, with decreased resting heart rate and blood pressure. So for a normal person, we see that the number of heartbeats per minute is 72, but those people who participate in regular aerobic exercise, you might note their resting heart rate is 65, 60, and also their blood pressure is low. And this physiologic adaptation will reduce overall cardiovascular morbidity and mortality. But in comparison, static exercises such as weightlifting, I know you know weightlifters. There is a guy who a TikToker known as Anatol. That guy lifts weights. It pretends to be let me not go there. But static exercises such as weightlifting is associated with pressure hypertrophy, and these may not have the same beneficial effects. So weightlifting is not as healthy as you think. So I know there's a person from our classroom that's lifting weights. Maybe I'd advise him that. So we have come to the end of that, and thank you for your attention, guys, and subscribe for more content. Thank you.